Thank you very much. Good morning to everybody. So in this talk, I will review the clinical assessment of patients with CLL. And to do that, I will take the current guidelines as a bottom line, and I will underline those issues that could be considered as controversial or worth to be investigated. These are my disclosures. And to start with, I will say that CLL, small lymphocytic lymphoma, and monoclonal B-cell lymphocytosis are closely related. The diagnosis is based on the monoclonal B-cell lymphocytosis in blood with an atypical immunophenotype sustained for at least 3 months. Here, the key issue is whether a time period of 3 months should be kept in the era of cell markers. In patients with more than 5,000 of lymphocytes, the diagnosis is CLL, while those patients with less than 5,000 clonal lymphocytes, there are two possibilities. One is those who have lymphadenopathies are small lymphocytic lymphoma, and those with the absence of lymphadenopathies or spleen or liver involvement are monoclonal B-cell lymphocytosis. Another important issue is why we have a diagnostic threshold which has been established as 5,000 lymphocytes. As you can see here in this slide, the higher the number of lymphocytes, the higher the risk of progression and the need of therapy. So then we can say that this threshold is somehow an arbitrary threshold. However, I must say that this is necessary in order to have a universal criteria for the diagnosis of CLL. Besides the use of markers, this has been already mentioned by Andy Rawstrom, there are some additional markers that may be helpful in some difficult cases, such as CD200, which has been already incorporated in international guidelines because it's very useful to distinguish CLL from, for example, mantle cell lymphoma, and some other markers such as ROR1, CD43, and etc. Importantly, in cases with a typical immunophenotype, it's very, very important to discard the possibility of a mantle cell lymphoma and to perform the cyclin D by histochemistry and FISH for the lesion for the translocation of 1114. The take-home message here is that an atypical immunophenotype should be avoided because the diagnosis, a typical diagnosis of atypical CLL is not a diagnosis. Let's have a look now at the key elements in the medical history of a patient with CLL. So we can see here that it's very important to assess comorbidities, obviously to have a family history of CLL, other lymphoproliferative disorders, autoimmune disorders, and also neoplasias, different cancers. It's very important or must be relevant to have some past clinical laboratory exams in which we may appreciate maybe the presence of lymphocytosis some years ago. Additionally, the physical examination, of course, is important. Signs of anemia, thrombocytopenia, lymphadenopathy is very useful and is needed to look at the extranodal involvement and to consider also to make an exhaustive examination of skin lesions, because we know that patients with CLL are more prone to develop skin cancers. We have also to perform, obviously, a blood test and also along with flow cytometry and other chemistry parameters which may be useful. Lymph node and bone marrow biopsy are not essential for the diagnosis, and they have to be performed if they are clinically indicated. And the imaging studies, they are not essential again, and then they have to be performed if they are clinically indicated. But are other tests at diagnosis useful? Because of their prognostic value, the case has been made such as whether TP53 aberrations and IgA3 mutational status should be performed at the time of diagnosis. However, in clinical practice, we have to keep in mind that only patients with active disease should be treated, and in addition, with the only exception of the IgA3 mutational status, the outcome of biomarkers may change during the course of the disease. So this is an open question. Are outcome predictors useful at diagnosis? While one of the advantages could be to advise patients, the con will be to create unnecessary worries. This topic will be covered by Barbara Herhorst in more detail. So let's see now what current guidelines and IWCLL, the NCCN, and the recent proposal by ESMO say about the clinical assessment just before starting therapy. So we can see here that there is, in general, an agreement in all guidelines in terms of basic exams, and also in terms of the performing a bone marrow aspirate and biopsy that should be only done in those cases which are clinically indicated. For example, the best example could be a cytopenia of uncertain origin. For example, I had in my clinic a few months ago a patient, an elderly patient with an anemia, and then the patient had, I performed a bone marrow aspiration, and the patient had a myelodysplastic syndrome. So I think this is very important to have in the differential diagnosis in patients with CLL, because we can have some concomitant hematological malignancies. Obviously, serum chemistry, importantly the renal function is very important, DHT, also the dosification of the immunoglobulin levels, but not other immune function tests. And viruses, of course, are very relevant when we plan to start an immunosuppressive agent. And even in the era of targeted agents, we have to test for the hepatitis B, not only to check at the antigen, the surface antigen, but also the anticore. Hepatitis C, so in cases which are hepatitis B positive, and some other CMV, HIV, which are all in all guidelines are stated. Additionally, it's important to test just before starting therapy FISH cytogenetics, particularly the deletion of 17p and p53 mutation and the IGHV mutational status. I might say that it's of interest that in clinical practice, these molecular biomarkers are infrequently performed. In terms of imaging studies, so this has been very controversial for many years, and now I can say that CT scans are frequently performed within clinical trials, but in daily practice, CT scans must be only performed if there is a clinical indication in some symptomatic patients. What about clinical stages? So clinical stages rely only. They are very simple, and they rely only in the lab test and also in a physical examination. This is one of the reasons why clinical stages have been used for many years, for more than 40 years after the development. Of course, to assess the lymphadenopathies in clinical stages is very, very important, and we are able to assess this in a very simple manner. You have here the figure. However, there are much more lymphoid areas that can be involved by the disease. And additionally, in clinical stages, they do not consider the size of the lymph nodes. So how to overcome these issues? So the obvious answer is imaging studies. So in this regard, so there has been many groups analyzing the role of the CT and PET CTs in CLL. As you can see here, there are several studies, and in summary, so the two messages is that in early stages, an abnormal CT may predict clinical progression. And in terms of PET CT, it has been associated with the development of Richter syndrome. However, there are two caveats. So there are false positive cases, and additionally, there is some indication that the PET CT is not as useful. The PET CT is not really useful in patients receiving B-cell receptor inhibitors, as has been shown that in the context of chemotherapy, it could be useful. However, still the diagnosis of a Richter syndrome is still needed a biopsy to perform. So the take-home message here is that the general recommendation in all guidelines is that outside clinical trials, imaging studies are not necessary for diagnosis, surveillance, routine monitoring of treatment response or progression. And they must be all investigated within clinical trials on when we have a patient with clinical symptoms. Therefore, identifying a reliable surrogate for lymph node involvement and bulky disease could be really useful in patients with CLL. In conclusion, current guidelines ensure a uniform diagnosis and management of patients with CLL. IWCLL, NCCN, and ESMO guidelines show a high degree of concordance. Because most patients with CLL are not treated in academic centers, guidelines must be as simple as possible, but at the same time should identify areas deserving research. Guidelines must be adapted to new treatment agents and management tools, regular updates being necessary. However, modifications in guidelines should be based on robust practice changing data. Thank you very much for your attention.
Thank you, Dr. Moreno, for this excellent overview. And this presentation is open for questions. If you can please come to the microphone, identify yourself.
Thank you, Carol. Pete Hillman from Leeds. Very good summary, but I think one of the questions about imaging, which you mentioned, and that we still recommend it in clinical trials, but you could make an argument that we shouldn't be doing it in clinical trials either. As we get more effective therapies, we're doing more imaging more frequently, and the cost and the potential harm for patients increases. So could we make an argument that actually we shouldn't be doing any imaging at all unless there's a clinical indication to do imaging in a particular patient?
Yes, so I mean, it's agreed. So I mean, it's probably we are incorporating the CT scans in order to have, to know more about the role in CLL. So I agree, I fully agree with you that we don't have to, to perform so many CT scans, even in the context of clinical trials, because we have some data showing us that is not really, there is no role in CLL. Although most of these studies that I summarize in that table are retrospective studies, so probably to discard whether there is any role of this, so maybe it should be investigated within clinical trials, but not many CT scans should be performed, yes, I agree.
Thank you. From the right side.
Hi, Carol. Michel van Gelder, Maastricht, Netherlands. Here, over here. I think we should add CT scanning when we start venetoclax to assess the TLS risk. So maybe we should add this in guidelines.
Yes, well, when I say that the CT scan should be performed when clinically indicated, I was referring in some cases, and one of the cases could be just before starting therapy or venetoclax therapy in order to measure somehow the bulky disease and to assess the risk of tumor lysis syndrome in this patient just before therapy. That could be an option.
One more question on the left.
Hi, Dr. Brian Kaufman, CLL Society. Do you know of any research that shows a correlation between the clinical exam of adenopathy by just palpating the patients and the nodes that you can feel versus the whole level of adenopathy in the patient in the mediastinum, the abdomen, the pelvis? Has there been any study of that correlates? Could we rely on our fingers rather than on imaging?
Oh, yes. So there were some attempts from MD Anderson looking at the levels of CD20, soluble CD20, in order to measure somehow all the lymph node areas in CLL, but there were no conclusive data, and I'm not aware of other studies looking at this. But that will be a very, very interesting, study to look at some surrogates of the disease, of the bulk of the disease in the whole body. Yeah.
Thank you. If there are no other questions, thank you, Dr. Moreno.
Thank you.
We will now